Hello, my name is Rosemary Mitchell, and today I will be talking to you about immersive virtual simulation training for workplace violence against nurses. We're going to cover prevalence of workplace violence against nurses, the current prevention practices, associated costs of workplace violence against nurses, and immersive virtual reality. Prevalence of workplace violence. The problem of workplace violence toward nurses in the healthcare setting is a very old problem that just seems to get worse each year. One of the problems is that it has caused a negative mindset to develop amongst the nurses. They actually have come to the belief that it is a part of a nurse's job to get basically beaten up, spat on, called names, punched, kicked, scratched, and they take it all in stride. There's no accurate count of the actual number of incidents that occur each year. And this is due to nurses that have been attacked that don't sustain injuries. If they were pushed or shoved, they don't report it. Or if they got spat on, that's something that they don't readily report. And this problem has not been adequately studied, which is kind of hard to do if nurses don't report. Also, there are nurses that have been attacked that are undertreated. If they get a scratch, it's like, oh, I'm okay, it's just a scratch. It has also not been universally defined. The problem of what constitutes workplace violence toward a nurse there is no consensus as to what constitutes that. For one hospital, if a nurse has been pushed, that is workplace violence. For another one, it's just an incident. The problem is also underregulated by law. There's a law against violence against factory workers. I mean, you going down the highway, and if you speed through a work zone, you're going to get a ticket. You get in trouble. However, until recently, there was no law that regulated or made it a crime to actually hit a nurse or kick a nurse. Also, many facilities lack policies and staff training to recognize and manage patients that display escalation in hostility and assaultive behavior towards them. So, I'm going to look at a chart here. This is the OSHA-recordable workplace violence injury incident rate. As you can see, the nursing assistants, they're at the very top. One of the main reasons for this is they are in more contact with the patients than any other area. The nurses, they're in more contact than physical therapy, than the physician or the dentist. The nursing assistants are the ones that are doing the bathing. They are doing the feeding. They're actually helping to get patients up and doing a lot of the ADLs for those patients. In this graph, over a 2-year period, we see that the incident of workplace violence toward medical profession escalated each year. There's an increase in it, with the nursing assistants still being the highest level of workplace violence. Between 1993 and 2009, the workplace violence was 20% higher amongst healthcare workers than any other workers, the industrial workers, sales personnel, manufacturers. So medical professionals were 20% higher. Now, between 2002 and 2013, the healthcare workers that were seriously injured in the workplace was 4 times more than the private industry. So, whereas a healthcare worker has 7.8 cases per 10,000 full-time employees, other industry only had fewer than 2 per 10,000 full-time employees that were injured while on duty. So let's take a look at the graph here. As you can see, the green line, this shows the healthcare and social assistant, and it is the highest This is per 10,000 full-time employees. As you can see, the red line, manufacturers, at the very, very bottom, it's almost overlapped by the blue line, which is construction workers. So there's a large gap between other industries and the nursing. Nurses have been injured, hip injuries, shoulder injuries, arms, neck, face. They've been spat on, bitten, kicked, punched, scratched, pinched, shoved. And this is from the Joint Commission 2018. All of these, and a lot of these, they don't think that it's workplace violence. Being spat on, hit in the face, slapped, pinched. Since there is no general consensus of what constitutes workplace violence, a lot of them have not considered that. So a lot of it is not reported. 80% of the serious violent injuries, which these are injuries that require time away from the job, sustained by healthcare employees in 2013, were caused by the patients receiving the care. Yes, there are times when patient family members, such as the well-known case of the Boston physician that was killed by a patient's family member. The grandmother died, and the grandson came back and killed the physician. That's a well-known case. But the overall, lumping it all together, 80% of those serious injuries were caused by the patients themselves. Now, here we'll see the graph showing the patients 80%. Now, other persons not specifying means that we don't know if it was a sister, brother, cousin, auntie, uncle, whatever, but they only accounted for actually 1% of the population that have caused workplace injuries to nursing staff. In 2014, the American Nurses Association, they conducted a survey of 3,765 nurses, and more than half of them had been verbally abused by patients, and 21% had been physically assaulted by patients. In 2015, they did another survey, and they reported 43% of nurses and nursing students had been verbally abused, and an increase in the physical abuse to 24, from 21% to 24%. So as you can see, each year it increases. Now, with this graph, we're showing here the different areas, and this is for violent injuries that resulted in days away from work. And this is by cause. The light blue show the ones that are hitting, kicking, beating, and shoving. Nurses that work in the psychiatric area or the home health aides, they have the greatest amount of injuries that result in days away. And then come the registered nurses and the licensed practical and vocational nurse. And it's divided up. This chart is divided up into, like I say, the type of injuries that the type of assault that they receive. Injury by physical contact with a person while moving them. This could have been from the wheelchair to the bed or the bed to the chair. And this is injury by other person, which is unintentional. Intent was not known. And then we have the injuries by physical contact with a person while we're trying to restrain them. If this person was trying to slide out of the chair and you're trying to keep them from hitting the floor, and then they start swinging on that person. Intentional injury, that's not been classified elsewhere. This could be anywhere from throwing urine in the person's face. That's considered an injury. You're injuring their eye, or slapping them. Now, this is a comparison of OSHA, the recordable injury incident rate per 10,000 workers per month by occupational groups. So if you see the patients that caused injury, workplace injury to the staff by patient handling and movement, large number of those happen. Slips, trips, and falls, workplace violence. And once again, you could see the nursing assistants still receive the highest, I should say, number of injuries for each one of these categories, because they are in that direct care. They are the ones that are with them a lot more than the nurses and the physicians and all the other healthcare, the dentists, the interns, the therapists. So what are our current preventive practices? So in California, it is a requirement now that all facilities keep a log of any violent incidents that they have. And from that log, they develop a prevention plan. Say they've never had a patient to spit on a nurse. Well, guess what? They've got it in the log, so now they're going to develop a prevention plan to keep patients from spitting on nurses. Don't know how they'll do that, but that's what they have to do with the logs. And then at the Cleveland Clinic, they installed metal detectors in their emergency room. They implemented the use of wireless panic buttons, and those are in the ID badges of the staff. They provided de-escalating techniques for the staff, and they also included having plainclothes police officers in their ED. They look like patients, but they're actually plainclothes police officers. Now, with the metal detectors, when they installed those, they collected knives and guns from people coming into the emergency department, either with family members or to get care of themselves. Another facility, what they did was they trained employees on how to recognize when they were in a dangerous situation and how to, when they're in that situation, how to get help. And they also educated the employees on some of the most common violent scenarios that can occur in their work areas, in their specific work areas, I should say, and provided, just different techniques for them on how to get out of it and get help. And one of the techniques was, if you're behind the desk, try to position yourself to the door. Don't have your escape route blocked off. If the person's going to throw a punch and you're right there with a book, a phone book, grab the phone book and let the punch land on that book, to keep from getting hit in the face. Mount Sinai Beth Israel Hospital, they implemented classroom education. They implemented a STAR program called the STAR Code Protocol, and that is Safety Team Assessment Response Code Protocol. And what it consists of is a classroom education, and then they had a simulation workshop. And with that simulation workshop, they did a debriefing. And in the debrief, they would go over with the staff, okay, this is what the incident was, this is how you responded, here are some suggestions and ideas of how to handle that situation. They also provided tip sheets and put them all over the hospital for the different areas. Another facility had just online training programs, which there's a plethora of those out, so you can learn about any kind of workplace violence against nurses. OSHA, and recognizing this problem, OSHA has developed and provided a voluntary guideline for healthcare facilities. It is not mandated that facilities follow these guidelines. It is just a recommendation, guidelines for them, something to help them to get the ball rolling, to help prevent workplace violence. As of today, there are 32 states that have actually enacted a law that makes assault or battery against a nurse a felony charge. So we're waiting on the other states. Right now, it's just 32. There is another facility. They did the prevention and safety protocols for their facility. They installed panic buttons. They've got a safe room. They did de-escalation training and some basic self-defense training, like if you're grabbed, how to get out of the person's grips, or take, like I say, the phone book and putting it up, or even your clipboard. You got a clipboard, so they don't punch you, they'll punch the clipboard. They implemented a facility-wide violence code with response teams. So when they called, Dr. Armstrong, then they know that they're calling a code because there's a violent situation, and the team responds. They also implemented a policy of zero tolerance for any type of violence. So any type of violence in that facility is a reportable event, and they are tracking those. Another facility did staff courses and education on workplace violence, so the staff will be a little bit more aware. This particular facility, the nurses were saying that they did need more. One facility, they increased their hospital internal security, so they have more security guards on. They installed new video surveillance equipment. They installed wireless panic alarm system remotes, and they have access control doors also. So you have to have a badge to get in. Also provided courses on violence prevention and de-escalation techniques. And then we have another facility. They did training that included classroom training with lecture and videos. And then they had simulation scenario training and some hands-on basic defense techniques. And it was based on those basic defense techniques were based on the area that the person worked in. Now, that is similar to PMDB, which the VA used, Prevention and Management of Disruptive Behavior. And they have been using PMDB, although it has been improved. The VA has been using PMDB since 1970. And the first part is online course that you take. The second part is a classroom. And you basically are talking to the person doing de-escalation. The third level is more de-escalation techniques. However, it also teaches you to recognize the signs of if the de-escalation is not working. So the signs of person getting more agitated. And the fourth level is they cater that more towards the emergency room and mental health. And this is how to physically restrain a person without you injuring them, or them injuring you, or anybody getting injured. So, some of the associated costs with workplace violence against nurses, it don't just affect the nurses, the employee, it affects the patient and the employer. The employee may experience physical injuries or even disabilities such as loss of vision or hearing because they've gotten gouged in the eye or hit so hard that they're bleeding from the ears, or they could have gotten thrown or landed wrong, caused a back injury that's going to now be chronic pain because they've had like a small fracture or something. But it also causes psychological problems. They can suffer from nightmares, flashbacks of the event. They start losing sleep. They could actually be diagnosed with PTSD. Some of them you will have an emotional reaction to the event. They can suffer from short or long-term anger because of it. They're angry at the employer for not helping to keep them protected. They're angry at themselves because they should have been better trained. They're angry with the patient or the family member because they have no right to attack them and they're trying to help them. They can have sadness that will slip into depression and anxiety, where they're at the point they don't trust any patient or anybody. They could be frustrated because they don't feel like the hospital protecting them or doing enough. They could be blaming themselves, like, I should have known better. I should have been more aware. I should have. And they can have irritability with all as an effect of being attacked. Now for the patient, this causes the quality of patient care and patient outcomes to decrease. And this will be due to staff quitting. The field of nursing is already short-staffed. So the person is victimized. They can say, hey, I'm out of here. Their coworker can say, hey, she got attacked. I'm not taking any chances. I'm leaving. So it can cause a ripple effect for other staff members to resign also. Patients can also be at risk for medication error. If the nurse taking care of them comes back to work and they've got some psychological and emotional effects because of the assault, they're distracted. This can cause them to cause a medication error. Also, it can increase the infection rate. If that nurse is distracted, then maybe she's not using aseptic or sterile techniques when she should, or not washing her hands as frequently as she should because she's so distracted. And you've got a patient that's a high-risk infection, and she's passing that infection on. She's getting poor sleep. She's anxious, so that puts the patient at risk. You could also have unintentional patient injury. If that nurse is on taking drugs to cope or taking alcohol to cope with the violence, then that's going to cloud her judgment. She can actually cause injury to a patient. She go in a room, she trips on a tube, the chest tubing, and she is under the influence of drugs and don't really register in her mind that this is happening. She just walks out. That patient is either intubated or something, or unconscious, and that chest tube is out. She's intentionally causing harm to that patient. Unintentional, I'm sorry, unintentional. Okay, the associated costs to the employer. The employer is going to have to cover the workers' comp insurance payment. You're going to have increase. They're going to have increased nursing staff absenteeism. The person that got injured, the co-workers could be calling out. They don't want that to happen to them. So, I'm looking for another job. They'll call out. Also, you're going to have increase in staffing turnover. And depending upon the incident, if it was somebody brandishing a weapon, they could have damaged the property. So guess what? The employer's got to replace that damaged property so that the place does look nice. You don't want somebody come in there with bullet holes all in the wall. Litigation costs. They could be taken to court by either the nurse that was the victim or the patient's family that the person was not aware of what they were doing and you let them do this. So family members can sue. Medical care of the injured staff. If the injured staff requires continued medical care, employer is going to pay for that. Psychological care, they might need counseling. Lost wages because they are out. In Minnesota, there was 344 non-fatal assaults, and this cost the employer $5,885,448 in just 1 year. And to replace one RN for them, it was $31,643. And to replace one LPN, it cost $17,585. There were 900 workplace homicides each year. And this has in the United States, and that carries an estimated charge of $4.2 billion annually. And 1.7 million is due to the non-fatal assaults. Now, there was one multi-system hospital in Mid-Atlantic. It had the main hospital, but it had 8 other related hospitals. They were of the same, but had 8 other outlying facilities with it. And they had $94,156 that they had to spend for nurses that reported injuries and required treatment. Now, $78,924 was for the care, and then $15,232 was to cover the lost wages of those injured nurses. So, hospitals spent approximately $22,000 to $64,000 to replace one nurse. And most nurses believe that it does no good to report. They feel like it's part of their job, so we're not going to worry about reporting it. Now, one of the issues with workplace violence against nurses is an area that's not regulated very well. And because we lack the data, we cannot actually verify the depth and the level of the problem. And until we get a handle on that, we will not have an accurate number. We will have a guesstimate. We will have research studies that are done small populations or small areas, but to get a true number and true value of what it's costing, we're going to have to actually have a database established, and then putting that data in. And also, we're going to have to get nurses to start talking and reporting any and all workplace violence. Many nurses believe that, it just happens with mental health or it happens with the emergency room. No, that is not true. No setting is completely safe from workplace violence from a patient. ER and mental health are just higher risk areas. Workplace violence can happen anywhere, and therefore all nursing staff need to be trained, not only on the fact that it can happen, but they need to be aware of different cues to alert them to it, how to de-escalate it, and how to keep themselves safe. Patient violence against nurses increases the cost of health care, because when you have a nurse out, then the agency, the employer, has to pay another nurse to come in. They pay them overtime to come in and work because that nurse is out. One nurse is out injured. Or they utilize agency nurses, which, of course, we all know agency nurses are paid a lot more than the regular shift nurses. Now, my idea is to integrate immersive virtual reality into the training. So, what is immersive virtual reality? This basically is a computer system with a specialized interface device. It could be the headset or a head mount display with the gloves, or it could be the body tracking sensor. You couple that with a 3D graph program and create a specific computer generated environment that's capable of changing with the movement of the body and the head. So this advanced technology, it can monitor the user's position. Whoever the user that has on the head mount or the body tracking sensor, it will monitor that person's position and movement, and it sends that information to the computer. When the computer gets that computer generates a real-time sensory stimuli, and it creates an experience that corresponds to what the user of the headgear or the body tracking system will see or hear in the real world. Now, this form of training is designed to create an experience that is specific for each user. Everybody is not the same because everybody's not going to respond the same. When a person go to throw a urinal at one nurse, she might just stand there and freeze, whereas another nurse might duck to the side right quick. So each person's experience is going to be unique. Now, this system can also be used to evaluate the staff member's performance during a variety of challenges and distractions. So that helps the employer. The employer will know then how to cater the training for the nursing staff. Okay, this is Dreamscape, and it is a virtual reality program. You can see she's got the goggles on with the headphones on and the battery backpack, as well as the sensors on her hand. And the real person is a young lady with the red shirt and the black pants on. But she is shaking hands with a simulated person. And you only see a pair of floating hands. So this is like huge, huge, huge for the world of actually nursing and medical care, because it's a safe environment for nurses to train in. But you're getting the realistic experience. Now, this immersive virtual reality avatar, it used to take them weeks and months to generate an avatar, because you had to take the picture, send it off, and then you have the gamers or the programmers to develop the avatar, do their little magic, and poof, you have the avatar. Now, according to Haptical, they can create an avatar in 10 minutes now. So that's a game changer for us. We can actually have the program to generate the avatar. If the nurse wants to put herself in the simulated world and she doesn't want to use a lookalike avatar, she wants to use her own. Guess what? 10 minutes we can have the avatar created based on utilizing that program, and she could generate her own simulation experience using her own self as the avatar. So the use of immersive virtual reality as an additional format, not as a replacement, it can be used as an additional format for training staff in ways to prevent and react to workplace violence. This benefits the facility because it provides the necessary training to keep the staff safe. It reduces the cost of providing training because the program is not a one and done program. It can be reused and adjusted for a specific individual. So we're going to reduce the cost of providing the training through the use of program that can be adapted, and it's going to provide the training on violence without actual acts or threat of harm to the staff member or the simulated assailant. So you get that real time life experience. Yes, you'll feel your heart rate will go up and it will feel like it's real, but you're actually in the virtual reality, but you're not physically getting harmed. The nurse is not physically getting harmed, but you're doing harmful training, if that makes sense. Immersive virtual reality also offers a safe and valid setting for staff to study and train for workplace violence prevention and interventions, while at the same time removing the danger of the staff of workplace violence. So that is my recommendation. These are my references for simulating virtual reality, immersive virtual reality simulation. And I thank you so much for your time.